To session 3 of the Kent County Medical Society's session on racism, equality, inclusion, and just overall discussions on cultural differences and how we take that into the exam room and with our colleagues. So today we've moved from the discussion we had in the last couple of weeks, which I'd recommend if you want to watch, you can go to KCMS and email us for the links to that at kcmsoffice@kcms.org. So there's discussions with Dr. Ned Sullivan and Knuster, and we discussed basically racism and the role of, I guess, medicine, and became actually a wide-ranging discussion in society as well. So a couple of things: make sure when you come into the room, you will be muted, and we're going to have this is recorded, so try and stay appropriate, everybody. You can send questions via the chat function in the Zoom. And at the end of the session, we will have a door prize for those still on the line. I'd like to thank the Kent County Medical Foundation for the generous support. And again, I'm Dr. Eric Larson, former past president of the Kent County Medical Society, also the host of the Paradox podcast. That's Paradocs. You can find it at theparadox.com, where I talk about the medical delivery system. And today I'm joined by two doctors here in Kent County, Dr. Belen Amat and Dr. Nirali Bora. So Dr. Amat is the founder and owner of Direct Primary Care of West Michigan, board certified in internal medicine and pediatrics. She was born and raised in Mexico City, where she studied medicine at the Universidad Panamericana and graduated with honors. She completed her internal medicine and pediatric residency through GRMEP, back when GRMEP was a thing, in affiliation with Michigan State University College of Human Medicine. Dr. Amat currently serves as the KCMS Secretary and Treasurer and serves as the interim regional director for Region 5 of the MSMS House of Delegates, representing Berry County. She's been a member of Kent County Medical Society since 2017. My other guest is Dr. Nirali Bora. She currently serves as the medical director of the Kent County Health Department. Lucky you, there's nothing going on right now, right, for you to work on. She received her medical education at the University of Michigan, completed her family medicine residency at Brown University, and is currently working to earn a graduate degree in public health at Johns Hopkins. She's been a member of the society since 2018. Again, just a reminder, this will be recorded, and use the chat function to ask questions if you want to watch this later or have other people have access to it. Again, you can email us at kcmsoffice@kcms.org. So first, thanks so much for joining me. And I guess we'll start out. Why don't we just talk about, our discussion today is going to be about other cultures and sort of how they work in medicine and sort of the challenges they're faced. So Dr. Amat, why don't you go first? Just briefly tell us just your background of, I guess, who you are and what you're doing in the area. And we'll have to mute that. Then why don't you go into just a basic background of training.
Thanks, Eric. And thank you, Patty and Mariana, for organizing this. And of course, Eric, for being a wonderful interviewer. So I was born in Mexico City. My parents are from Spain. And I grew up in Mexico my whole life. And then I did medical school in Mexico, my rural service in a rural area that was beautiful, of course, but very remote in Mexico. And then I came to Michigan to do my residency in med-peds for 4 years. And then I just stayed. I kind of found my husband, and then I just stayed in Michigan. I love this area of Michigan and love the winter. I know. You know, you're going to say, it's like, how can you like the winter? I love it. So currently I own my own practice. I operate in a direct primary care model. So it's outside of insurance completely. And I have 362 patients as of today. Majority of my patients are Spanish speaking. So I would say about 80% of my patients speak Spanish from all over, from Mexico, Puerto Rico, Dominican, as far as Argentina and Ecuador and some other places in South America. So I think one of the things we'll probably talk about is how people find me and want to be my patients because I speak the language and I understand the culture. And it does make it a lot easier because I kind of know where they're coming from and I know how to talk to them. And it's not just the language, it's a cultural thing.
Sure. And as full disclosure, I'd also like to mention that Dr. Amat is my physician, although I'm not one of the 80% who speak Spanish. Un poquito.
I'm going to start making you speak Spanish.
Yeah, I know. Now I'm in trouble. All right, Dr. Bora, why don't you give us your background?
Sure. So my name is Nirali Bora. I'm a family physician, and I'm just glad to be here today. So thank you so much for having these topics. I think they're super important topics that we all need to be discussing as a society, and especially in medicine. So I'm excited to share my thoughts and my experiences with you. So I was born and raised in the US, kind of moved around a lot as a kid. My parents are both from India, moved here. So they're both immigrants to the United States. I went to high school in Grand Rapids and I left and was at University of Michigan for med school, was in Rhode Island for my residency, then moved to New Mexico to work with Indian Health Services. So I'm not Native American, which a lot of people got confused. They were like, you're not Navajo, which is where I was working, but they could not place me. So that was an interesting experience, but worked with Indian Health Services for a few years and then had my first child there and needed some help. And so came closer to be with family. My parents and in-laws are in West Michigan. And so then since moving back in about, I don't remember now, 2013, I believe, I worked at both Spectrum and Mercy Health, and then 2 years ago joined the Kent County Health Department as a medical director. And this is where I've been, trying to figure out a pandemic with all of you.
Yeah, of all the times to take on that position, right? You had no idea that was going to happen. So why don't we start with the first question that I have is, one of the challenges that we face in medicine, Dr. Amat, just you sort of mentioned that to begin with, but in medicine, we see everybody, right? I mean, we see people from anyone in the community, and oftentimes they're people that as physicians where, our socioeconomic class is different than most people we see, but we end up seeing everybody. We interact with all sorts of people from all over. And it turns out that lots of people we don't even know exist in our community. At least that's been always my experience, that I'm always surprised at how many people are from Guatemala, for instance, or Serbia. Yeah. And yet you're seeing all these people from, and so what is your feeling on what should we kind of keep track of as physicians? What's the most important thing for us to keep in mind when we walk into a room and you really don't know, except maybe you see the name looks a little bit unusual or different than what you're expecting from, West Michigan?
I think one of the things that I find that help is don't be afraid to ask. I think when you start asking, being weird about asking something, then it shows that you're uncomfortable, and then it makes the other person uncomfortable. And the funny thing is, it happens also in reverse, from the patients to us. So my patients know I speak Spanish, but then they don't place me as I'm from Mexico because I have fair skin. So they actually tell me, "Oh, your Spanish is really good." And so I get that too, of the reverse, kind of, they're like, "Your Spanish is really good, but I don't know if you are from Mexico," unless they really came to me because they know I'm from Mexico. Sometimes the language is what they are looking for, but they also don't know, and they don't know how to ask. And I think just being open about it and saying, "Hey, where are you from and where'd you grow up?" And just having some interest in where people are from. And maybe it's like Nirali, yeah, she was from West Michigan and then moved all over the place. It's very interesting to know her history.
Yeah, I think cultural humility, definitely, because I think even within a culture, there's so many differences, and there may be people who don't identify with their culture or identify with many themes in their culture. I really enjoy caring for refugee populations, and I can't even pretend to know about cultures, and especially, like, for example, in Myanmar, there are so many different cultures and ethnicities and languages, and so I think just for me, it's always helpful to say, "Tell me more about you. Tell me about what do you think about this? What are your thoughts on this? What language do you speak? How do you like to be addressed?" All of these things, I think I really don't have any shame in telling my ignorance. Like, I know nothing about this. Please explain it to me. And I find that most helpful.
How do you approach that question? Because the question people might ask you is, "Where are you from?" Well, that means where were you, this morning versus where were you 5 years ago or 30 years ago? How do you approach that conversation? Just that first question. How do you kind of start it off?
I think one of the things you said that is interesting is the name. So a lot of times it's asking about where's your name from, or what does that mean? Like my first name, people don't know first to fill if it's, male, female, but it's a very common name in Spain, and it means Bethlehem, the city. So I usually kind of help people figure that out and say, it's a name of a city in Spanish is a very common name. And I think it helps kind of break that barrier if you maybe start by the name. So,
Go ahead.
I was looking at that question. I don't know if I'm supposed to see the questions, but
Oh, I don't see any questions, so that's good.
on the chat.
So that's one of the thing that I struggle with, and I imagine this is probably for everybody, is that just like Nirali mentioned, you may meet someone from a country, but it doesn't really mean they're anything like what your preconceived notions are, or of the 10 people you met from that country before. Like, if you just said you're from the United States, well, we know that Texas is nothing like California versus Hawaii or Maine, right? I mean, they're all completely different, and the cultures are different. And I think it's easy for us to forget that the cultures can be different within, even though countries are smaller. They, like I know where my foster son's from Guatemala, but I think there are like 100 languages that are spoken in Guatemala, and Spanish is actually not his first language. And so there are always assumptions you can make that I guess you can trip you up.
And I think when we ask someone, where are you from? There's always a sense of making that person a bit of an other. You're not from here. Like the assumption is, oh, you're not from here. But maybe they are. Maybe this is where they're from. I get asked that all the time. And I'm like, this is where I'm actually from here. I'm not from anywhere else. The thought is, if you don't look like us, you're probably not one of us. And so I think just being careful when we ask that question. And I think I love your approach, Belen, about saying, tell me about your name, because that's people are attached to their name. They're proud of their name. They want to explain that, but it's a way of doing it in a way that's very gentle without making them an other.
Yeah, I will oftentimes ask people where the ethnicity of their name, just because I'm curious, whatever it might be. But so I think that gets to a good question for you, Dr. Bora, because the people who have immigrated from India is relatively recent phenomenon within a couple of generations. And so, but you're now to the point where there are people who have, lived their entire lives here. And so they're as much American as anyone else, but you don't look like the traditional white American or whatever. And so how do you navigate that with not only your patients, but also with colleagues, or do you not find that as much of an issue with colleagues?
I guess I don't find that an issue with colleagues. And with patients, I don't think it's an issue. I think it's often just a matter of people are curious and want to know. And so I'm just very straightforward with it. No, I was born here, but my parents were not. And that usually answers it. And when they ask where I'm from, they don't want to hear that I was born in New Jersey. So I mention it, but I'm like, well, I was born in New Jersey. Do you want a whole life story? I can go there. But no, my parents are from India and I was born here. That's usually enough. And it doesn't bother me when it's from a genuine curiosity. If it's from from someone's trying to decide, oh, is this person too different to be my doctor? And that's when I find it starts to get a little bit on the more offensive side. But that's very rare. And that happens like maybe a couple of times that I can think of. So.
Did you, with your training program, did you feel like you had, the things were unique because of your background? I mean, for Belen, you were, I guess, a foreign medical graduate. Mm-hmm. For Nirali, you're not. You're American, U.S. born graduate. Did you find that the way I don't know if I could say the program or other residents, I mean, after they know you, I suppose, but did you find a different way that you're sort of like had to interact with people because of who you are?
I don't think so. My program is very small, and I think I'm probably the only in the history of the MedPeds program in Grand Rapids. I'm the only foreign medical grad, but the medicine program had more than half of the residents were foreigners. So I think that helped kind of that I was not like the center of attention, but it actually brought an interesting thing is my clinics became kind of the hub of a lot of Spanish speakers because they knew that I spoke Spanish. So then I drew a lot of Spanish speakers, and it helped the other residents also have a more diverse population. So I think that was a positive thing. I think one of the things I saw in residency that was a little hard and it was new to me was what people would say, especially like other doctors would say about Mexicans, right? When the patient's not there, or when they didn't know I was from Mexico. And first of all, assuming that everybody speaks Spanish is Mexican, where even, the Spanish you speak in Mexico, Guatemala, Honduras, Spain, Argentina, Venezuela, I mean, it's completely different. It's the same language, but it's like British and American, right? There's nuances to it. So I think what was hard for me was to hear those comments about people from Mexico that were just assumptions. Like in the ER, an attending said to one of the residents, and not to me, but to one of the residents, and I was sitting right there, well, this family, they're Mexican and they really don't follow up. They never follow up. Those Mexicans never follow up. So we need to make sure that, you call the clinic in the morning and make sure they get seen. And I was very offended because I was like, well, first of all, they're not Mexican, they're from Guatemala. And second of all, that is very offensive. And I did say something, which now I'm like, wow, I'm proud of saying something, but it came out of this feeling of being offended, of saying, why do you assume, first of all, that they're Mexican? And second of all, that they don't follow up because they're Mexican? That has nothing to do with culture. Maybe they don't have money to get to the appointment. Maybe they don't understand the discharge instructions because you're just giving it to in English, or maybe the interpreter is not, and that is always an issue in medicine, is the interpreters have to translate word by word, and a lot of things are lost. And I think that just being aware of the things we say sometimes when we think people are not listening, but you're right there, and you can never know who's listening, and you just have to be very careful. And then maybe it brings up your own bias that you don't know you have.
How did you, so with that conversation, how did you approach it to make, I mean, because I think you could just be offended and just be angry, but you can or you can look at it as, well, maybe this is someone who just didn't even think about it. And that there's an opportunity to teach someone how better to navigate that situation. What did you do? How did you go?
I was an intern, and I had like not even a clue that this was an issue. So I did respond from being offended. I think with time, I became more helpful, like on the floors, maybe they didn't have an interpreter, and I would volunteer and say, let me help you with this family because I understand where they're coming from, or I can help you. And then I would actually pick the patients that spoke Spanish. Like when we did our patient list, I would pick those patients just because I know it's easier because I didn't have to wait for an interpreter. And then it would help the families. And I didn't mind when people asked me, can you help me with this patient? Because it comes from a different place of maybe I'm not understanding the patient is non-compliant. So I think just assuming those things, but I did change a little bit of how I approached it because I didn't take it so personal, I guess, when I learned where people were coming from is a place of maybe they don't know. It's not necessarily mean. It's just don't know.
Did you have any experiences like that or something else, Dr. Bora?
I mean, I don't feel like I had any concerns in training or any issues that I saw in training. We had a pretty diverse faculty, and we had a very diverse patient population in Rhode Island. So a lot of people from Cape Verde Islands, Portuguese, a lot of refugees, African American, just a wide mix. And so I think people were used to seeing a variety of physicians as well. So it never felt like it was that different. I think what I found interesting, especially when I started practicing here, was that patients who were patients of color, especially African American, felt much more comfortable talking about racism with me. And they said, I wouldn't feel comfortable telling anybody this, but I know you'll understand. And, coming from, I'm not an underrepresented minority in medicine, coming from a more privileged background. And so I wasn't sure that people would feel comfortable saying that, but people did. And they said, and they would talk about the experience of racism that they experienced and, how it was affecting their daily lives. And so that kind of felt like, I felt honored that they felt comfortable to share that with me. And I think being a woman makes a difference too. And so my female patients felt much more comfortable in talking about those situations. I think there was less of a sense of a power differential in some of those situations. So in those sense, I think it actually has been a benefit to seeing that I'm maybe can relate more on certain levels.
What has your experience been then as a woman in medicine? I mean, we're all sort of the same generation where it's much more common to have women in medicine, but I still think there are many who are practicing who are older, or patients still are surprised that women are physicians as much as, that maybe young people are now.
I guess
it's
one
still,
thing.
yeah, go ahead.
Go ahead.
Go ahead, Nirali.
No, sometimes I think just the expectations are different sometimes from, I guess, from nursing staff and from colleagues in terms of like, I think there's a lot more expectation that women be friendly, nice, chit chatty, all of that. Like, with the office, like I need to know how all my nurses are doing, my medical assistants, how their lives are, how their weekends were. And, I enjoy doing that anyway, but I think there's an expectation that you have to do that. Otherwise, you get labeled pretty quickly as that doc in the office who, has certain personality. And it's interesting because my husband's a physician as well. And he'll get these awards from nurses for being so kind and helpful and all of these things. And he's like, but I do that all the time. And I think it's, when it's coming from a male physician, sometimes it's valued. And I was like, oh, wow, he was so kind and went out his way to do that. But for women, I think that's often kind of how you have to be all the time. So just something that I've noticed. And so I'm glad you got these awards, and I tell him that I'm proud of him. But at the same time, I'm like, so.
Yeah, I think it still shows in patients their generation. You would come in the room, and now everybody wears a white coat, but even in residency, I don't think everybody wore a white coat. And you come in and introduce yourself and everything, and then they're on the phone and they're like, oh, the nurse just arrived. And you'd be like, oh, this work for nothing. Nothing against nurses. I mean, they do a great job, but you would like to be recognized for your profession and the years of training, and not just assume because you're a woman, you're the nurse. And that I think it's probably changing. I would like to see what residents think nowadays, if they get that still, or not as much. But it was a thing back then.
I think you're right. Depends on the generation of the patient. Like I remember doing inpatient rounds with some medical students, and they're male, and the people would automatically assume that I'm the nurse, and that's the physician in the room and the attending. And but I think that's changing too.
What do you feel like the relationship? You just sort of touched on it briefly, but what is the relationship with nursing? I mean, nursing is still dominated by women. How do you feel that they interact? You're now in family practice, so you're probably not in the hospital as much. But what's sort of the different interactions, and how do you think it's still a challenge for women as physicians?
I think it's one of those things that is very, it's kind of ingrained, that it shows, but you don't talk about it. I think it when you have like a male attending and a female attending, and you even in residency, you can see sometimes the nursing staff, especially female nurses, because of course there's male nurses, but the female nurses would come to the male doctors as like, oh, Dr. So-and-so. And then they see you and they'll be like, hi, morning. And you'd be like, what did I do? I didn't do anything. So I don't know if it's a competitive thing of females. I mean, I don't think it's exclusive of medicine. I think that happens in other environments where, a woman goes higher and then somebody's jealous or something. I wonder if that's what it is in the background. It's not so much medicine. I think it's just a female thing of competitive and see who's in charge, right? I mean, and being in Mexico, I had one of the jobs I did, I had it was all males, and then I was the boss. And one of them in the first day of work came to me and said, I've never had a female be my boss. I don't know that I can deal with that. Just like that. And I said, well, we'll see, right? And then it was fine. But he was open enough to bring it up. And I think that one of the things is we don't talk about it because it's very difficult, obviously. How do you talk about something like that? So I think like Nirali, I think I had to do it like extra, super nice, trying to always overcompensate to try to not rub off certain people, and I don't know if it's just medicine. I think I've seen it. I've worked in other areas of not just medicine, and I think it's not just common to medicine. I don't know, Nirali, do you feel that? Or?
I think I do. I mean, I think they're small examples that are, I sometimes just do a double take, like, did I just see that or did I not see that? Or someone rushing to go make coffee for a male doc. And I was like, oh, I like coffee too. When I precept, do you want to make coffee? It's just like they're small things that are not, they're not really that big of a deal, but you notice them and how people are treated. And then, often I'll be called Nirali, which I don't mind. I honestly like to be called by my first name and by my office staff, um, but it's for the male doctors, it's always, oh, doctor, and
Mhm.
I think it doesn't bother me, but I also notice it. And sometimes it does, and sometimes it doesn't. But I don't know. I can't articulate it very well right now. But
No, and I think I've seen that not only when you work, but I've seen it in conferences. So pay attention when we go to medical conferences, and the male physicians are Dr. So and so, and the females are called by the first name. And I didn't even notice it before until a friend of mine brought it up and said, "Did you notice that there's, maybe 4 males and 3 females up there, and the guys are doctors, but the girls are not. So what's up with that?" And I don't know that we even notice that we do that.
yeah,
To me, it was very interesting to even start noticing, and I notice it more now. I can tell that somebody's calling me by my first name, but then the guy gets called doctor.
Do you see that more exclusively from men or women, or does it not
From
matter? Does it matter what sex it
I
is?
think I've seen it from men more than women.
yeah, I think so too.
Yeah.
Do you find that with nurses? That I mean, I have a lot of nurses who call me by my first name as well, and so I always wonder how that works,
Yeah.
or if it's a generational thing too. I don't know. I mean,
I don't know that from nurses I now by myself, so I don't I still like the nurses the medical assistants that I had in my previous employed position. I even talk to them now and we socialize once in a while, go for coffee or something. I like to keep in touch with them because you're just, you work so close together. You kind of become friends, but they still call me doctor. They never call me by my first name. So to me, that's actually good for them, because they recognize we can have coffee together, but they also recognize that, their position, and it probably makes them uncomfortable to, that we're socializing when, I don't know, it's an interesting thing that I just observed a couple weeks ago, and I was like, it's interesting that I'm still Dr. So and so. So I think it actually might be the opposite with staff.
what is an example you'd use? I guess when it comes to interviewing, I think that's probably a different experience for you as well. I don't know if you've been on the end of hiring versus just being hired, but what do you've noticed the differences either from being someone from like Belen, an FMG, right, foreign medical graduate, or just a different ethnicity or culture than the person who's interviewing you?
Hmm. I don't think for like the major interview, and obviously for residency where you go into bazillion places, I don't think I noticed a difference. I think that residency programs are very culturally sensitive when interviewing foreign medical grads. So I actually did not have any of those issues when I was interviewing, or even the female issues. I don't think that there was any difference there. I didn't notice it anyway. I don't know.
Yeah, I don't think I can.
Mm-mm.
Yeah, no, I don't think I've noticed any differences there, either on either end of it. Whether I'm interviewing, I think I'm more. I mean, as when I interview, I think about having a staff that represents a population that we serve. So I'm very mindful of looking for people who are coming from underrepresented minorities. But I think that's the only difference. But that I think that anybody could do. I don't think that's related to me or who I am.
Well, I'd be remiss, Dr. Bora, since we have you and you're the director of the Kent County Medical Department. Can you tell us what's going on with can you solve coronavirus for us? No, but can you explain what you're facing right now? I mean, obviously we're having this little mini surge here as we speak now. Was it October 26, 2020? But what are you seeing, I guess, right now? And then what are you as a department planning and kind of preparing for the next 3 to 6 months, I guess, or I don't know what time frame we use for this virus. It seems to change every 2 weeks.
Yeah, there's a lot there. I think so. We've seen our highest number of cases to date. On Saturday, we had 326 cases, which is significantly higher than anything that we've ever seen. So it's worrisome. Our positivity rate is consistently trending upwards. Our hospitals have more patients with COVID than they did before. So we are concerned, probably more concerned than we ever have been throughout this entire pandemic, especially when we see that the fear isn't there. I think there's a lot of fatigue in the community. People are tired of masks. People are tired of not socializing. So in the context of that, and I think there have been a lot of political challenges with COVID with our state as well. And so I think that's confusing. I think we need, I mean, there are a lot of things I think we need, but I think the more we can be all on the same page, I think it'll be helpful. I think having this happen right before an election is poor timing. So yeah, I mean, we're worried about a lot of different things. We're doing a lot of different things right now. What I worry about is what's actually going to help. What can we do that will actually make a difference and make people concerned who may not be concerned, and make something that we really wish wasn't political? How do we make it less political than it really has become? One benefit, I guess not benefit, but one good thing that we're seeing is that the disparities in the Latinx and Black communities that we saw initially, we are not really seeing right now. We don't have the full testing data. We don't know the negative tests completely that we're getting from all the other testing partners in town. But from what we do see, the percentage of people that are positive for the Latinx community matches the Latinx population in the community, and same with the African American community. So that is heartening to see. So that is one silver lining in all of this. The numbers are still going up, so there's still concern everywhere, but the disproportionate increase is no longer there as much.
Well, this kind of gets back to the cultural issue as well. I mean, when you look at trying to disseminate information to communities, you've got one community that may not even speak English or not much, which not necessarily, the Mexican, Hispanic population, but it could certainly be people who are from other countries, which we see all the time. We were talking before we started, wherever they might be immigrating from, whether Africa or a place in Europe. How do you get a unified message to those people so they kind of know what's going on? Because I imagine they're not someone that probably are, plugged into the county health department. I mean, most people aren't anyway to begin with.
Right. And so right from the beginning, we saw what was happening in other parts of the country and in Detroit, and the disparities that were pretty significant. And so we started creating liaisons or connections to different communities so that we would have very regular points of communication. We wanted to be transparent. I guess that was what we wanted to start off with. We wanted to make sure that people had the information that we had. And so one of our nurses is the liaison to the Latinx community. And so she's been having meetings. In the beginning, it was once a week with Latinx GR. She is trilingual. She speaks Spanish, Portuguese, and English fluently, but she is Caucasian and not culturally Hispanic. But so she's done a lot of interviews, Spanish radio, TV stations, newspapers, constantly, as much as we can. We also have a community health worker. We've expanded her hours, so 20 hours a week. She sets up a table. She's bicultural, bilingual. She'll go to testing sites all over the area. She'll go to grocery stores, Hispanic grocery stores. If there's an event with the Mexican consulate, she'll be there, and she'll provide information, mental health resources, food services, whatever else there is, and just explain things to people if they have questions. And so that's been helpful. Trust is a big issue. I mean, we're a government entity, and while the health department is not connected to, the jail and other things, we're still part of a county government. And so there's a lot of mistrust there. And so a lot of it has been really emphasizing that, in our testing sites, we are not looking at documentation. You don't have to have any kind of information to register for testing. We'll cover the cost if you can't cover it. So really emphasizing those points over and over again. We have a call with urban churches once a week, primarily Black community there. We talk pretty regularly with Black Impact Collaborative. We meet with Native American community pretty much on a monthly basis. We've been meeting with refugee communities. In the beginning, it was with a wide variety. We meet separately with Vietnamese, Bhutanese, Burmese, Vietnamese, the Congolese community, and it got to be too much. I was on meetings every other week. I couldn't handle it anymore. So we started coalescing them. So we have a refugee meeting once a month right now. We've hired someone temporarily to really work to improve our connections with refugee community leaders. We have some that we connect with very well, some that we realized we had not been connecting with the Sudanese community at all. And so we have someone, she's actually a former refugee from Sudan who's been working with us to really strengthen these connections in these past couple months, so that when we do reach out, we know exactly who to connect with. And we're working with the refugee resettlement agencies and organizations to build that network. So going forward, we'll have a stronger communication network. And we translate everything. We have about 10 languages that we try to get all of our materials translated into. Our webpage is in Spanish and Vietnamese. And I don't know, it's been a lot of efforts. I'm not sure where it's going. I hope it's helping somebody somewhere, and that we can continue some of this, but it's expensive. And so I know we can continue Spanish. I'm not sure what funds we'll have going forward to continue all the 10 languages, but at least we know what's needed, and we hope we can get more feedback on what's been helpful. So that's a little bit of it. But.
Yeah, that's it. Well, those are the challenges you don't think about. I mean, I would say that I don't know if we talked about it during this session or when we're on live, but definitely you don't recognize the diversity in the community. I think, you think of West Michigan, you think of Dutch. I mean, I always joke that I felt I need to change my name to Vander Larson when I moved to town, but certainly there are tons of cultures here, and it's a very large metropolitan area, even though it's not as big as Detroit or New York, but we definitely have a lot of people. And you spend any time in the labor wards and you will see people from all over, and, you needing interpreters and things like that. So Dr. Amat, you mentioned that you've got a large Spanish speaking population that has found you. You went off into private practice. How does your, your ethnicity or your culture, what does that mean for your patients, and how do they find you, and how do you sort of reach them?
So initially when I opened, I really didn't know how to approach patients, because we're not used to selling ourselves, right? We just sit and the patients come from the insurance company. So when you don't take insurance, you have to get out there. So I through the Chamber of Commerce, surprisingly, a couple of guys that are from the Hispanic community, they connected me with the media. So I started first talking in the radio and the newspaper that are in Spanish in town. And that was like the first few people. And then most of, I think, the patients I have are word of mouth. So maybe it was just one person, and then that person brought his family. And then, I mean, I have some families that I have not only 3 generations, but like 5 this way. I mean, if I just put a last name in the computer, and I have like maybe 20 or 30 people from the same family. So I think they all refer each other, which is very nice, because obviously it's like the best compliment you can have is like, here's my doctor, and I think that's how you want to look for a doctor. You don't want to look in the phone book, if it exists. I don't think that phone books exist, but you don't want a billboard to choose a doctor, right? You want somebody that you can recommend personally. Is like, who do you know that does this? And I think we all do it, right? We want to do it personally. So initially I did do a little bit of more of a media thing, and then now it's been word of mouth. I still talk on the radio regularly. With COVID, when the lockdown, I was on the radio, La Poderosa, which is in Spanish. Pretty much every week we would do an hour reviewing everything that happened in the week, and then it got exhausting, and now patients take more time, and I'm completely sucked in by taking patients with COVID, so I don't have as much time to do interviews. But I think word of mouth was pretty important, and I think patients value that I understand when they explain something about food. I understand it. It's just the little things. I know that you can't tell somebody from Mexico to not eat tortillas. I mean, it's impossible. There's no way, because guess what? In Mexico, people use tortillas as a spoon. And so how are you supposed to eat with your hands? Is weird. So understanding that it's not just to make tacos. Tacos are one type of food, like burgers. Tortillas are part of the culture, and especially handmade tortillas. Oh my goodness, they're delicious. But understanding that, and then Mariana's like, oh my God, somebody gets me. But if I say that to somebody from Dominican, they probably look at me like, what, are you crazy? Right? People from the islands, the Caribbean, they eat rice. To them, it's rice. So when you're training, and give the carbide, examples because of all the diabetics I take care of, very prevalent diabetes. So knowing those little different things, and also from Spain, so I have I think a more diverse understanding of all the Hispanic differences from the different countries, that I can touch them in that way. And so they then say, oh, she understands this. And then I can bring my mom now, and I can bring my brother, who I can't get through to him, but you will. And I think one of the important things also in the Hispanic culture, and I don't know that it's in all the Hispanic countries, is the doctor is a highly respected figure, is the doctor and the priest. That's it. So having that power, I know some people might say it's paternalistic, but it works when you use that to help the patients, because they will listen to you culturally, they will respect what you say. Is what is the doctor saying? And then that's why the radio was so important too with COVID, is I'm the one telling them to put their mask on. Oh, la doctora, the doctor said this. And some arguments in the store actually ended, they brought me up that I said something, and it was good for the store that they could say the doctor said this. So little things like that, I think, is a lot of value.
And you, I mean, you trained in Mexico, right? And then you were United States. So you really actually never encountered most of these cultures when you were training, I'm imagining, in Mexico, right? So how did you get to the point? Because, the dumb Americans like, well, they speak Spanish, are all the same, right? So how did you sort of navigate all these different cultures and learn about them? I mean, do you have trip up lots of times and have all kinds of problems at the beginning?
Not really. I think it helps when you speak the same language, but so I trained in Mexico City, and Mexico City is like being from New York City. It's like you're it, and there's everybody else is rural. So, so I really didn't have a lot of contact with any sort of anything outside of my social circle of very privileged people. But then when I went into medicine and I went and did rotations in public hospitals, I started seeing a little bit more of that. And then my rural service, like I said, you go out there and live for a year in a rural town. You are the town's doctor for a whole year when you finish med school, and you're it. And so living in the community, if they didn't have electricity, I didn't have electricity. If they didn't have water, I didn't have water. We all got sick from the same things. So living in the town helped me a lot. And then I did do some mission trips in Honduras. And then here in Michigan, I think I've gotten to know more of the Guatemalan population and where they're from. And obviously to them, so one of the important things is know that Spanish is their second language, like you said, for your son. And things like that, I think I've learned through being here in the US. Before that, I mean, in Mexico City, I wouldn't see anybody from Guatemala. It's all from Mexico. So I think traveling is what opens your eyes, right? When you travel and you see different things in different cultures, that's when you're like, oh, I didn't know you guys ate this. Or I thought all people that speak Spanish eat with tortillas. Well, that's not how it goes.
Well, it is the only way to eat eggs. That's all I eat, eggs. Yeah, it's actually interesting because my foster son, like I said, he's from Guatemala, and when he grew up in rural area in Guatemala, but he only thought there were 3 countries in the world. He had never heard of any other countries besides Mexico, the United States, and Guatemala. I mean, and even to get to Mexico, you have to travel through Honduras, but he never heard of Honduras. I always found that very interesting. The world is in some ways very small, that these people live in the rural areas. Anything else you guys can think of that we should discuss, or about the culture and sort of dealing with that as either physician dealing with our patients or with each other? Any questions from the crowd?
I have one question. As we look to 10 days from now, is there any thought of kind of an offensive where we go and talk to churches that may be polarized one side or the other, that are not being helpful right now, or other organizations who maybe, if their battles immediately are reconciled one way or the other, will they maybe be helpful in a sort of a new wave of information in helping with the virus and compliance and so forth. I guess it still would be polarized some ways, but there may be some leaders who have a vested position right now who might be receptive to a new visit by somebody, one of you workers, saying, we need you to reach this group of people who are suffering. You maybe have new numbers to show them in 10 days that you're not going to like showing them the way it's going. And we haven't begun to see what the impact is of this microparticle stuff in the air. As we get closed inside, I think we're going to have a real uptick in infection. And I got my car repaired the other day, a new shop my mechanic bought, and it's just a little closed office space and kind of closed heat, and nobody's wearing a mask. And I just said, you're just looking for trouble. It's a nice new little office you have here, but this is where we have to wait while you fix our car. And we're going to get sick. I had my mask on, but I still didn't feel very safe. I went outside, but I was just disappointed. They're both older guys, way overweight, just looking like an accident waiting to happen. So I just wondered if anybody's thought of a phase 3 educational thing, maybe from the county society or whatever, to bring people on board who've got a political reason to stay off right now.
We'd be happy to talk to anybody who's open to hearing us. So yeah, I think there's definitely room for that. We're really talking about what kind of messaging can we send that's not, I don't think people want to hear from the health department anymore. So how can we put out messaging that's through other messengers? Let's hear from families who had loved ones who've had COVID, who've had children who've been struggling, who've managed. Let's talk about small businesses, how they've managed to work with this. And I think we need stories that make it seem real. For a lot of people, COVID still doesn't seem real. It affects other people, but not them. Or the people that they know have been asymptomatic and have done well. And so how do we capture stories and share those? So I think that's kind of where we're leaning. If there are other ideas, honestly, we're open to anything. So yeah, we're happy to talk. We're happy to have other messengers, whatever we think we need to do.
Do you find that this has been very strange. I don't think I've ever known of any sort of disease or infectious process or something like that has become just so political. It's just very, very weird. I don't think even when HIV was had just started. Now I was just a kid, but it didn't seem partisan or very political at that time. There are certainly people who had their opinions on it, but I don't feel like people were sort of hardened into sort of their approach to the disease. How do you, have you talked to other health departments? How do you convince someone who sort of has, for partisan reasons, let's just say, they feel one way or the other? How do you get them to sort of listen to each other and to each other's concerns?
I think those are the questions we're all asking each other right now. I don't think we have any great answers for that. I think once it hits home, once people see that it truly does, affect their families and their loved ones, I think that's when people start making a change. For some people, they're willing to do it from the beginning. For others, it needs to be closer to home for that to happen.
Yeah, it's kind of sad, but I think I've seen that with some of my patients that initially are like, it's not a big deal. And then all of a sudden they get sick, or they get somebody who's really close in the hospital, and then is like, I think, and we've seen that with, politicians or people that are famous, and now they've experienced it, or they have somebody sick close to them. And I don't know, I think maybe something that we could do as a King County Medical Society is having maybe people that are in the front lines do some sort of fire chat. I know Patty's taking notes of this, but and I would like to know, I want to hear from the people in the ER and the people in the ICU. And we hear from other places in the US or other places in the world what they're struggling with, but I want to hear from them as a primary care doc, is like, how can we help you? And how can we educate people about what you're going through? And like you said, Nirali, just using the examples and the history, the story with somebody they know. I think it's maybe more personal, right?
Even simple Zoom videos of providers talking about their experiences and what they've seen, I think would be helpful. And I think we're seeing a lot of young people who don't think it's real, or only affects the old people and not them. And so how do we make it seem real for younger folks too? So even talking to pediatric providers, who worked in the ICU, I know there have been children in the ICU in our county with MISC. So how do we get some of these people to come together and talk? So our public information person is reaching out to all the hospital systems information folks as well with these questions. But I think if the medical society could do something, whatever social media, whatever format it can be out, I think it's always valuable. And I think doctors are very respected and people really trust their physicians as role models too.
Any other questions from the general audience or any other points?
Just a thought is that we could have a prepared campaign ready with some media support and so forth to try to make Thanksgiving safer for people in the week after the election, you know, just begin to get people to put together a Thanksgiving that would work in a safe way. You know, I think they're talking about limiting the number of family groups that come together or whatever, how to do that and trying to just, because it's quite a dangerous time, it looks like, you know, it'll involve lots of us seniors who want to be around family, miss family. But anyways, it just a thought, some idea like that would seem like something we could be behind, and maybe we can get some support and a positive thing in the community. And if we could, I don't know, somebody, if epidemiologists know what kind of Thanksgiving we should be trying to have, you know, we could market that somehow with help from maybe the grocers and Meyer and W and so forth might help us explain how to. They just want to sell product, but they might be interested in keeping us safe.
Sure.
That's a great idea.
I think it's a great idea. I can just say for KCMS and KCOA to partner with each other.
Yeah, I think when it comes to a lot of these things, you know, we're struggling, and I don't know if that's the right term, but I think, you know, we're trying to figure out how to keep ourselves engaged with each other in this time, because I mean, have as much problem as anyone else does as our medical society. This is even extends back long before this COVID-19 hit, to try and engage and make this a value for everybody. And so I think if you have ideas for things that we could do either for future chats, I think that'd be very helpful. Again, you can send those to KCMS office at kcms.org. And really we want to continue conversations that people are going to find meaningful, and they're going to find that will help them in some way in their practice or in their career. I think, you know, maybe we'll do some social things as well, just to opportunity for people to visit, but we want to try and stay connected because it looks like this is going to last a while. and it'd be nice to at least address the issues that are important and that we find meaningful in our lives now. So I'd like to, I think, wrap things up and thank Dr. Amat, Dr. Bora for joining us today, and Dr. Bora for all that you're going to be doing in the Kent County Medical. I'm sure it's only just starting, really. The insanity that will probably happen next year as they try. Hopefully there's a vaccine that rolls out, and then the administration and distribution of that's going to be very challenging, I'm sure. I'd like you to continue watching KCMS website at kcms.org. Again, thanks to the Kent Medical Foundation for sponsoring this. We always have a door prize at the end. I don't know, Patty, how many door prizes do we have? Do we have 1, 2?
Go ahead and do 2. We
2,
can do
okay.
2. All
right. So the last one we did, I use I use a random generator to pick people who are present, and it was all anesthesiologists. So now I promise that was
sense.
Yeah, I know there's people didn't believe that was actually random, but so I think everybody in here. So I just know it's gonna end up one of my partners, but I'll do
of course.
Okay.
You need some music. Dun, dun,
No,
dun, dun.
I know. My problem is I had everyone on the same line, so I gotta.
Oh,
yeah.
Okay.
But it's nice that we have so many people who are present. So
Yeah.
Fortunately, now that I use an electronic medical record, I'm very quick typing.
You gotta get carpal tunnel.
I think that's everyone. Oh, I almost left off my partner. Okay. All right. We'll try this again. Random choice, Brian Roloffs.
Hey.
Hey, all
Yay.
right. And number 2 will be Herm Sullivan. Thank you. The star of last show.
Can I
So they-
donate mine?
You want to just maybe pick someone else? Herm,
Yeah,
that's fine.
can I donate it to one of our speakers?
Well, they'll be getting one for themselves. So
How about Dr. Vander Larson? Can he accept mine?
Vander Larson is fine. How about we give one to Quinn? That's the next random choice. Dr. Quinn. And I think that should be it. So I thank you all for joining me. And oh, hey, there you are.
Yay.
Your camera works. You've been hiding the whole time from us. Again, thanks again so much for joining us, and hopefully we'll do this again, and tell your colleagues to log in, and hopefully this is value. And again, if you have ideas, please send along to kcmsoffice@kcms.org. Thanks so much, everyone. Have a great evening.
Thanks.
you very
Bye.
Thank you.